So, just for those of you who don't know, this is the new name for the unit I work for, which was previously the RHOU. It's now called the Institute for Sexual and Reproductive Health, HIV and related diseases, and we spend every night saying it in front of the mirror, trying to time it. So anyway, so I've been told, so after fighting for years to get the CD4 count as high as possible, Francesca made me take this side of the debate about when, and essentially the debate is increasingly with antiretrovirals, it's not when to start, it's when not to start. And I want to make a strong argument for why I think 350 actually is perfectly reasonable with our current knowledge base, and that we actually have to wait for better knowledge before we start saying, let's shove everyone on antiretrovirals. Now, Francesca and I and Dave have come to the agreement, so this is the terms of the debate, is that if somebody comes to you with a CD4 count of 600, insurance test, government's HCT campaign, whatever else, and they had a CD4 count of 600, for those of you who don't know, that means very, very healthy, good functional immune system, would you advise him to start ARVs? I've made it to him, or we suggest it was to him, because there's a whole lot of issues around pregnancy and stuff which we thought we wouldn't get into. I don't think there's much debate around TB co-pathology. If you've got cancer, we think you should get antiretrovirals. If you have TB, you should get antiretrovirals, even though the government guidelines don't say that at the moment. And around pregnancy, we think you should get triple therapy. I think that I'm hoping we're not going to debate that. I want you to think about things differently. Okay, so since I can see there's a few people in the audience who have at least some sort of risk factor around this, what happens if you have a 1 in 10 chance of having a non-fatal heart attack? That's, for many people in the audience, that's pretty much what you're looking at. Would you take mildly toxic tablets every day for the rest of your life, attend the doctor every 3 months, have lots and lots of blood tests, so that you can cut that down to 1 in 12? Because that's what I think we're talking about here. Now, I'm not sure I would. I have this joke about how, if you look at the stats around diet, if you believe the numbers, if you eat essentially boiled fish and boiled vegetables for the rest of your life, you can cut your risk of a heart attack by about half, but from a very, very low level to an even lower level. And I enjoy food too much for that, and I can take you through an alcohol-related one, which I'll spare you of, but yes, I think that most of us would agree that we think twice about that. But that's pretty much what I think you're asking. And I think that's why I would argue that until we have better evidence, you have to be very, very careful, because I think this is the best we're looking at. Would you do it? So, firstly, I need people to realize that this is largely an academic debate. It really feels like when you're in ICU and you sit about discussing whether you should use augmentin or first or second generation cephalosporin. It's very similar to that. Is that in fact, across the world, the average CD4 count remains at 80 to 100. So we're quite lucky when we find the occasional patient who creeps in with 600. There are very, very few of them. And you might say, well, let's, it's only in South Africa, it's like Middle Africa. In fact, it isn't. It's across the world. You can see that the average CD4 count at initiation of antiretrovirals is a very famous graph now that is highest in Australia. But in most of the world, including in the States, it's less than 200. And it's not just, it's even in really, really good academic clinics. This comes from the Johns Hopkins cohort. You can see since 1996, it's actually gone down, the average CD4 count. So even in America, where you'll see a lot of these guidelines come from, it's actually a bit of a non-debate. You're quite lucky to get into care with a relatively preserved CD4 count. I can actually stop the debate here because I've won just based on this graph. But yeah, this was a study that came out of the Lancet in 2008 that looked at mortality rates and cumulative mortality over time. And you can see how if you don't get antiretrovirals, or you don't get dual or monotherapy here, and these are all developed world cohorts, you can see that the death rate at about 10 to 14 years is almost 50%. In the era of antiretrovirals, they compared it to the general HIV negative population. And you can see there's almost no difference. So Francesca and I are now going to argue about how big that difference is there. Okay, now none of us debate the 200, less than 200, less than 350 group, which is sitting in that group there. We're going to sit down, we're going to argue about that, which you can ask yourself, how clinically relevant is it? Are you going to be amongst the unlucky group, there's a nice big 100% living there, that 2 or 3% that's actually living there, or you're going to be part of that. So, next. This is the hysterical American guidelines, which essentially say you should start ARVs below 500. And here when it says panel divided, in fact, it's not really that divided. They're even more hysterical than that. 55% and strongly recommended, and 45% moderately recommended, this area here. And you can see 50% favor initiating therapy at this stage, and 50% view initiating therapy at this stage is optional. This is more than 500. Okay, now, moving to the next slide, which summarizes all the guidelines. That's pretty much the way the world's going. I'm always irritated by the fact that they're busy talking about the British guidelines, the IS guidelines, when our guidelines probably inform far more patient care than all of these combined. But anyway, for what it's worth, you can see there's only one tiny little group here, which is kind of in this European cohort, to suggest deferring therapy if they have a low viral load and if they're asymptomatic with a C4 count more than 500. So generally the world seems to be moving towards this. And as I said to you, I find that the data to support this actually very, very weak. WHO, who generally far more evidence-based, paradoxically, than most other guidelines writing committees, have gone with the C4 count of less than 350 irrespective of symptoms. Okay, and I think that I would certainly argue that the data for that is relatively strong, and I'll come back to that in a second. The rest of the guidelines I think are completely uncontroversial. So when I said I was doing this debate, some really, really rude friend, because I largely have rude friends, sent me this paper, which was published in the BMJ, which some of you may have seen. It's one of the funniest papers of all. It's essentially a gynecologist obstetrician, which really gets my hackles up, arguing that evidence-based medicine is a lot of codswallop, and that we have no evidence that parachutes work. Okay, we think they work, as they say, to prevent death and major trauma related to gravitational challenge. So what they suggest is that we run a randomized controlled study where we throw a whole lot of evidence-based believers like me out of the airplane and we randomize them to either getting a parachute or not getting a parachute and see whether or not there's a statistical difference in terms of how much in death and major trauma. And they said to make it really, really scientific, it should be a crossover study. So that if you eventually back out and get the parachute the first time, the second time we would make sure that you died and you had major trauma. I would argue that this is very simplifying what is actually a very, very complicated debate. And when my friend comes, I am going to tell her next time she comes around how wrong she is. So just to re-emphasize that below 200, this is data from Steve Lawn, which shows this dramatic increase in mortality below a CD4 count of 200. Okay, and I don't think any of us debate it. Below 200 is bad, and he calls it the death zone. He says in South Africa, we're waiting in the current government guidelines, which says treat below CD4 count of 200 by and large, unless you're pregnant or you've got TB, as we're allowing them to enter the death zone. Okay, and I think that's true. And I think government acknowledges that it's true. But what are we arguing about? What about the magical 200 and even more magical 350? And there's a study that was done in HETI that came out last year. It seems to indicate that there's definitely benefit to doing it. The study, which was supposed to compare 200 to 350, actually compared 140 to 280 and demonstrated significant benefit. And I think that in terms of randomized controlled trial evidence, we can all rest easy that there certainly is benefit starting above 200 and below 350. I think there's very little debate about that. But the problem with it is that we tend to magically now make the number higher and higher. So it's needlessly going to creep up. And I want to show you why I think that's wrong. So again, this is a paper that came up, it was in the archives entitled Andrew Bull's data, which demonstrated this dramatic mortality below 200, which I showed you earlier. But here he shows you the patients who got ARVs below 200, over there, their mortality, and it's not insignificant, about 8% of them are alive at almost 2 years. And then the mortality of the ones who got ARVs above 200. And that is about a 10% difference. Okay, it's not as big as you'd think, the way people carry on about starting over 200 and 350. Okay, fair enough, but you could say, I still, if it was me, I wouldn't really want that 10% difference. Cool, let's accept that. So just to be really nasty, I've taken a study which Francesca helped design, okay? And this study, which was conducted in Joburg and Cape Town, which was published in AIDS, and the rest of it was actually published in the Lancet, I think, about late last year. Again, took patients above 200 and less than 200. The primary design of the study was not to randomize them in this way, but it was just an observational look. And again, you can see that there was about a 10% difference between those who started less than 200 and those who started over 200. So if you started over 200, you had a 10% chance of dying, and if you started below 200, it's crept up to about 18–19%. What's interesting, though, is that if you look at this data here, the low risk of death, that you had a less than 1% chance of death during the study period, which was conducted over 2 years. That's interesting, is the longest period of follow-up, there they've said less than 1% chance of death. It's pretty good going, as far as I'm concerned. And here we've got another study, this time again for Andrew Bull, who did this massive pooled data set that compared the responses to antiretrovirals. If you look here, there's 25 patients who started below a CD4 count of 25. You can see that 15% of them are dead. I can't remember how many months this went out to. I haven't cut and pasted the graph across correctly. But you can see here, when you compare the groups, just between 100 and 199 and more than 200 again, you see a very, very small difference. It's quite astonishing when you start thinking about it like that. Because that says to me that there actually isn't a hang of a lot of difference in terms of actual responses. This comes from a developed country, so you might be thinking, look, I'm feeling developed and I don't fall into the squatter category. This then starts analyzing those, and here you can see again that the risk of death, if you walk backwards here from your CD4 count, then you can see, as you'd expect, a dramatic increase in death compared to a CD4 count of 400. But over here, which is the area we're looking at, there's not a hell of a lot of difference, to be honest. And in fact, all these confidence intervals all happily cross each other. Granted, there's a trend, but that one and that one isn't a hell of a lot of difference. This is the CORD study, which is probably, I think, the strongest study to probably support Francesca. But even there, the relative risk ratio of waiting for less than 350, at best, you almost double your prevention of death by starting at more than 500. But you start off from a very, so your chance of dying is halved, pretty much, by going on antiretrovirals early. But your chance of death in the first place was pretty small. And the way I think about it is that I can give you triple therapy to stop mother-to-child transmission, and then I can add a cesarean section to halve the risk even further. But we don't do that, simply because the triple therapy is so effective that simply adding the cesarean section seems to be pretty much not worth its salt. So what we have here is, the other thing is that people keep talking about non-AIDS complications, the long-term complications of heart attacks, strokes, liver, and kidney disease. And certainly for me, that would be one of the things that would worry me. But as you can see here, in many of these studies which are quoted, they tend to agree with each other, but they're not completely in agreement. So there's some sense that either the studies weren't big enough to detect it, or that maybe the signal that they're showing isn't as important as we think. This is the final study, I think, on AIDS and non-AIDS events, but again, they had to put this into a log actual instance to try and demonstrate the difference. What you're actually seeing here is a graph that looks like this. And the difference here is actually extremely, extremely small. Again, at high CD4 counts, they're not seeing many events. So there's not a hang of a lot that's happening here. It's all happening at the low CD4 count. And there's some more stuff. There's some worries. Particularly, this is all data that was presented at CROI last year. And there's in CROI that's happening, starts on Sunday. So we'll probably get some more evidence. But increased rates of HIV-associated neurocognitive disorder at lower CD4 counts. Again, it tends to be at the very low CD4 counts. Increased arterial stiffness with cardiovascular risk. Increased risk of fracture. Again, most of this is with people that's demonstrated that in people with very low CD4 counts, like in the area of 50 and 100, that these things tend to happen. The same goes for the opportunistic infections. The interesting thing about this is that there is a gradation, but the gradation looks like this. So the risk you're starting to get of this, even though where it is statistically significant, it's really hard to tell because you need such big numbers to show it, is extremely small. So you can have two perspectives. You can have your individual. So would I take antiretrovirals if my CD4 count was 600? And certainly a year ago I would have. I had to think about this debate and try and persuade myself otherwise. But what would you do if you were a health minister? And I think both of those are very different debates. Are there any pros to starting earlier? You are definitely less infective. If you're on successful antiretroviral therapy, you are actually technically sterile in terms of transmission of the virus. You have been rendered non-infectious. Now, we don't tell our patients that, and we whisper it quietly in corridors, but for all intents and purposes, the transmission risk to somebody who's on successful antiretrovirals with where viral load is completely suppressed, does decrease the infectivity. I'm just not sure that you're going to win that debate by saying I'm taking it for my partner. That's the health minister's debate, is to say, should we treat everybody to try and bring down the infective pool? I think I'd rather wear a condom than take therapy, triple therapy at any rate. Does it decrease TB risk? It certainly does. It's not clear, though, that you couldn't simply prevent that TB by taking lots of INH and doing a decent symptom screen. And I'm not sure by itself that I would take antiretrovirals simply to stop TB. What are the cons? Well, the estimates at the moment is that the antiretroviral costs would increase immediately by approximately 50%. And you might have seen the health minister's, well, Gordon's speech yesterday. The reality of it is that we are already having a very, very stretched, very large health budget. It's almost doubled in the last few years. And in fact, the WHO estimates that if we went to 350 for all, it would cost an additional $2 billion a year to treat the whole of Africa. There's all the issues of drugs, lots and lots of drugs, and swallowing tablets, which we don't like. There's lots of blood taking. There's increased blood taking, particularly in the area of, and you have to put yourself into a system. There's increased health system utilization, which brings with itself additional costs. So if you're in to get your CD4 count monitored, you might as well complain about that little lump that's been bothering you and the sore throat and everything else. And it's time of work and travel and a lot of other things, which is all adds up. The other negatives is you're going to be on drugs for longer, so you're going to have a greater chance of resistance. There is potentially a greater risk of drug toxicity, although I must say that the data I found for this was relatively unconvincing, except for D4T. And there's the issue of inconvenience. I had a medical condition where I had to go to the doctor several times over the last, I had to go about 6 times to an ENT, in fact, I saw Dave Spencer there. So I had some weird infection in my ear, which I acquired in a river somewhere, and I was convinced I had cancer, or at the very least a brain tumor, or a teratoma, or something like that. So I did what all good doctors do, which is wait until you're practically deaf before you go to the doctor, and then went, but I tell you, just going through the bloody traffic to be at the doctor and sit in that waiting room. I just can't believe our antiretroviral patients put up with it. And it was only a couple of times, and needless to say, I did what also what good doctors do, which is default therapy and don't go back and switch it. So in the old days, we had a situation where we were very, very worried about the antiretroviral side effects. We've now got to the stage where we think the HIV replication is doing all the damage. So we rather go with this rather than that. Okay, and that's where the paradigm has shifted, certainly in the last 4 years. So do we need the trial? This is such common sense. Everyone says, no, no, just take the treatment, take the treatment. As I said to you, there are lots of things in medicine where people said, you're stupid to even not take this therapy. And I think my best example is hormone replacement therapy. You all were part of that. There was nothing wrong with hormone replacement. Women it should be put in the bath water, it should be put in the drinking water, it should be like made, fortified in the bread. Now, you've got to think very hard whether you want to take hormone replacement therapy or not. And now we're seeing similar things with some of the other immune modulators, but we had to put smart. A trial that came along and gave us a completely different result, even though we knew the answer before it started. And the magnesium trials in myocardial infarction in the mid-90s were very, very similar. So, yes, I think we need a trial. Their cohort studies are problematic. These are all observational studies. We do not have a randomized controlled study above 350 versus 500. There's all sorts of confounding factors. You have all sorts of streaming bias. There's lead time bias. And in many of the studies, the toxicity and resistance, which would be major reasons not to do something, were not included as endpoints. Luckily, we have an amazing study, which has actually started, which is going to enroll 4,000 patients. When you have to have a study of 4,000 patients, you're measuring something very, very small. Okay. So Barry Mendler from our medical school used to say, you know, when you have to measure the effect of B12, you have to treat 2 patients, you can see the effect. In cardiology, when you have to tell the difference between one therapy versus another, you have to put 50,000 people into a clinical trial. It's usually trying to sell a drug or to try and sell an intervention when the effect is very, very, very tiny. So in summary, it is plausible that there may be benefit in earlier treatment. I think it's quite clear that the tendency is that way, but it's not proven. Okay? I think that it seems, if I had to guess, that's probably going to be the way it goes. But do remember, the event risk, though, is incredibly low when it's more than 350. And especially if you're a switched-on patient and you're alert to the fact that losing weight and coughing and having a significant headache or that blue things growing on your skin is not a good idea. It's even lower because you're going to go and seek health care when you need to. Starting at 350 is associated with excellent immune recovery. I haven't shown the data here, but when you start at 350, your CD4 count gets almost back to normal in no time at all, and eventually will get back to normal. It's also got very low short-term problems. We don't know what the very long-term problems are because we haven't followed it and we haven't had treatment long enough. You might say, well, I don't want to find it out, but you could argue the same thing about the drugs. I think this is something that people don't think about enough, is that being in a medical system, as I said with my ENT, is a pain in the bum. It really is. There's no other way to describe it. Sitting in those queues, reading Time magazine from 2008 is like one of the worst things in the whole world. And I would not wish it on my worst enemy. And I do think that's something that we forget, is that people don't particularly enjoy being in our waiting rooms, or even being in the nicest Linksfield environment. Yeah, as I said, and to sum it up, is I don't think that there's enough data to say there's a blanket rule to advise that male patient will receive 4x600. I would say it's highly individualized. I would say, how's your partner doing? How are you feeling mentally? What do you think about? Are you feeling, there's often in our communities this concept of pollution, of being self-polluted. Does that make you feel better? I don't think, if it was me and I was positive, I probably wouldn't sleep too well at night thinking about these viruses running around my bloodstream. But when I think about it, there are lots of other viruses running around in my bloodstream, whether it's cold sores, whether it's old chicken pox, or everything else. So it's a little entirely rational response to having a viral load, So I think, and when you think about what your gut's colonized with, it doesn't exactly make sense that you're not sleeping at night because you've got a little bit of a virus running around your bloodstream, and your entire gut's colonized with every horrible bacteria on the face of the planet, and a half dozen fungi. So I would argue that this is where it stops, is that there's not enough evidence to say blanket-wise, this patient at 600 should take therapy. For a health minister, there's no debate at this point. I would wait until there's clear benefit in terms of stop of transmission. But certainly for the individualized approach, I think you're not going to be able to get away from the fact that 350 is where the evidence sits at the moment, and we need to wait for the START study before we start getting an American view of 500, 700, 800.
I'm going to partly be quite naughty and respond to some of Francois' comments as I go. So they are off the record kind of comments, which I will stand by despite everything. My talk is entitled The Sooner the Better. I don't know if you're familiar with this analogy at all. And if there are vegans in the audience, I'd like you to leave, because if you think pain in the bum was offensive, this is going to be more offensive. What it is it's a picture of a frog in a pot of water. And what happens with that is, if you put heat underneath that, the little froggy doesn't realize it's getting hotter until the little froggy goes bright red and dies. And that's the kind of analogy that I'm talking about, is that even though we can't see it, we've got a problem going on due to immune activation. Okay. The benefits, the public health benefits, and I'm talking now to the community, and I'm not talking about whether you should start someone with TB on antiretrovirals. I'm talking about, is there a benefit to the community? If you do not know that antiretroviral therapy prevents opportunistic infections and prevents mother-to-child transmission, that's the door. You're in the wrong meeting. I think the B2 meeting is next door. The other thing is it does undeniably decrease HIV transmission. As Francois says, we say it in private, not in public. And it does prevent TB. So let's have a look at the famous test and treat, which I will not belabor very much because I think we're all well aware of it. If we start at a CD4 count of 350, we will get our incidence down to a reasonable level. But if we bang everyone on treatment as soon as we find them, we will be out of jobs by the year 2020. And I'm sure by then some awful parasite that colonizes Francois here will be available. And this is just the model that goes with that. Okay, this is the big problem that we have. TB is a problem, and what can we do about it? Not for the individual. We know that if you've got TB, you need to go on ARVs for a whole lot of reasons. But what can we do for the community in general? Okay, this is a picture of the changes in the presentation in the number of cases notified for TB in the Western Cape. You might well notice that the solid line is quite a lot higher than it used to be, and that is one reason only, and that's HIV. The problem with it is that the more TB there is around, the more people will get it. So it doesn't matter your HIV status. If there are more bacilli around, you're more likely to cop it. So we need to have some way of controlling this. And one of the ways I propose is the use of antiretroviral therapy. This is a slide that shows you exactly what will happen if you are HIV infected. Your CD4 count starts at about 800, and it drops down to a very low level roughly 10 years after 10 years after seroconversion. If we have a look at the next one, this is what happens if you, as your CD4 count goes down, what your relative risk is of catching TB. Okay, at 200, we are not particularly surprised. At 200, it's a big problem. But if we have a look at 400, it's still a big problem. And even at 600, you have a higher baseline risk of getting TB than if you were HIV non-infected. So here we've got a whole population pool who are more liable to catch TB. And while we can argue that TB and HIV co-infection is less infectious because of the paucibacillary nature of it, it remains very infectious and spills over into any population, positive or negative. And then, as we see, the longer people are HIV infected, which is pretty much the reverse of that. So it doesn't matter what your CD4 count is, you're at an increased risk. And this slide also well demonstrates it. This is people on antiretroviral therapy, but these little blips are, if your CD4 count is 700, what is your risk of getting TB? What's it, 6? Here we're sitting at 400. It's still quite a significant risk. And although I'm sure you're getting bored of me saying the same thing, this is not only for the individual, it's for anyone who's breathing, which at the moment is most of us, and it puts everybody at risk of TB. There we go. You see, he's starting to feel a little bit warmer here, a little bit uncomfortable, and that heat is the heat of TB. I'd like to comment also on Francois' slides, that a lot of his data came from communities where the incidence of TB is not 940 per 100,000 every year. So we're talking about an exceptionally different population. And if you look at the two flat lines where he said he won the argument, well, what he forgot with that is that the argument was in a TB low prevalence area. Okay, so now we're looking at the individual itself. So where are our vulnerable spots? What is it that HIV can do to us and damage us? The first thing is, we used to think that before you got sick with HIV, it was dormant. But that's not true. There's a lot more immune activation than we ever thought. And they're what they call storms of cytokines. And if you wouldn't mind not asking me what the cytokines are afterwards, because it'll take me so long to explain, maybe because I'm looking it up in a textbook. So there's a whole storm of inflammatory processes going on. And they're not necessarily, let's put it even stronger, they're bad for you. And you get holes in your immune system that are permanent. And the longer you leave it, the bigger the holes. I love Francois greatly, but with respect, he is a little bit attention deficit. And that's why, when we look at immune surveillance, we're looking at kind of long-term complications. We're not looking at the short-term viral load undetectable by 48 weeks. We're looking at what's going to happen when our patients become grandparents. Is it possible? Absolutely. And it seems a great pity to save people from awful things like PCP, only for them to die of. Yes, I agree, these are all AIDS-related cancers, and there's a significant increase. The bottom line is people who are immunosuppressed from transplants, so you can ignore those. But these top ones are the improvement in the various cancers that are HIV-related. Okay? We're not surprised at that because that backs up what we're seeing. But here, even in non-HIV-related cancers, things like cancer of the kidney, that doesn't cross the midline. Melanoma, oh look, I think that's a bigger problem in South Africa probably than from this cohort. So we save people from certain death from something that's suffocating them, and then they go cop something else. And that does seem a pity to me. Coincidentally, and I accept this is not evidence-based, but I do a ward round at Helen Joseph looking at difficult cases. And about 6 months ago, it was D4T-related toxicity. The last 3 I saw were malignancies. They were still being characterized. One was a Hodgkin's, and the other 2 were still being categorized. So we're seeing something different going on here. Then more lactic acidosis. Okay, neurological disease. Yes, I agree with Francois. This is not based on randomized controlled trials. It is observational data, and yes, observational data does sometimes prove to be wrong. But again, it's very seldom wrong when it goes against what we intuitively think as doctors. Okay, so soon after infection, you can find a detectable viral load in someone's CSF. I don't particularly want viruses in my CSF. I don't really like the thought of it being so close to, where I think. And it sets up a chronic immune activation. And it does all these things with, again, cells that don't ask me about. But here it says white matter pallor, microglia and astrocytic proliferation, basal ganglia predilection, Personally, I don't want any of that in my brain. So let's have a look at what happens to the incidence of neurocognitive disorders as your CD4 count goes down. And this cutoff is a cutoff between above and below 400. Okay, so above 350, Francois does win. Below 350, Francois does win. There's no doubt about that. But have a look here. If we take this backwards, that's about 83% of patients are neurocognitively normal. 17% are not. The incidence, for example, in taxi drivers in this city is probably sitting in the order of 60. So 60% of people, of the taxi drivers, I don't particularly want those guys to have poor neurocognitive function. And again, this is a public health issue as much as anything else. Okay, if we have a look, this is kind of not 100% accurate because it's looking at an HIV viral RNA level, but it kind of correlates. Again, the higher the viral level in the blood, the lower, the more people have problems going on in their heads. I bet you guys can't guess what I'm going to show you next. Okay, this little guy's now getting really, really uncomfortable because I've never heard a neurologist saying, let's wait for someone to have a stroke and his blood pressure is actually 210 over 140. Let's really break it before we go and fix it. That doesn't make much sense to me. Finally, kidney disease. I appreciate that this is a bit of a soft argument, so I'm going to rush through, pretend I know what I'm talking about, but not really. There is HIV, which is HIV-associated nephropathy, which is much higher in black men. So really we've got a sitting duck. And what you see when someone comes in extremely overloaded with a low pH is the end stage of an ongoing problem. It's not something that happened yesterday. Like what's happening in the brain is happening in people's kidneys. Up to 25% of people who attend our clinics do in fact have microalbuminuria, which is a risk, well, it's a precursor marker of HIV. I stole this from a very clever student who did a master's at our university, and what they did is that they took out all the people who have pre-existing potential renal problems, and they had a look at how many people have microalbuminuria, and the answer is way more. But have a look, people who've got no or moderate immunosuppression, that's still quite a lot of microalbuminuria. 60% of the patients that they surveyed had microalbuminuria. So there's something cooking in these guys' kidneys, and we are just waiting for something bad to happen. As Francois mentioned, I think that there will be only one way to settle this debate, and that will be with the START trial, the strategic, trial of antiretroviral treatment, and then the answer will become apparent. And that's what I'm hoping is going to happen. Instead of the frogs boiling to death, the frog is going to jump out and be healthy. Thank you.